Welcome to the funnel effect. Today, we are opening up a really significant file, one that's fundamentally reshaping how we think about cardiovascular care and managing risk. We're doing a deep dive into some critical official guidance that's making waves in the medical community. It's drawn from the 2025 Concise Clinical Guidance, an ACC expert consensus statement on medical weight management for optimization of cardiovascular health. And we absolutely have to acknowledge the team behind this essential document. Olivia Gilbert served as chair, Martha Gulati as vice chair, along with Ty J. Gluckman, Michelle M. Kittleson, Rishi Riki, Joseph J. Sassine, and Beverly G. Chang. That's quite a lineup of experts.
It really is. And this isn't just, another paper with recommendations. This is the American College of Cardiology sending a very clear signal to doctors everywhere that, well, a new era in treatment has arrived. That's really the core message we need to get across today. Our mission here is to unpack this guidance because it marks, frankly, a clinical revolution. For decades, cardiologists tackle cardiovascular disease, CVD, by focusing on the usual suspects, blood pressure, cholesterol, smoking cessation, and of course, recommending lifestyle changes for weight. But this document firmly establishes that these modern, highly effective weight management drugs, the pharmacological tools, are now critical, proven agents for preventing and managing CVD itself.
And that really is the aha moment, isn't it? That shift in thinking. Weight management is no longer this sort of secondary concern or something just for appearance. It's now explicitly framed as a primary cardiovascular intervention. It's bridging that huge gap we've always had in treatment. We're finally moving beyond, the often frustratingly limited long-term results people get from just diet and exercise alone, but without necessarily jumping straight to invasive bariatric surgery. These newer meds offer real, life-extending, proven cardiac benefits.
Exactly. And the urgency for this shift is underscored by the sheer scale of the problem. If you zoom out and look globally, this guidance defines obesity clearly as a debilitating chronic disease. And it affects over 1 billion adults worldwide.
1 billion. That's staggering. It is. And to grasp how quickly this crisis has escalated, just consider this. Internationally, obesity rates have basically doubled in adults and quadrupled in children and adolescents in just the last 3 decades.
Wow. That kind of trajectory is, it's alarming. And it really highlights why the ACC felt this guidance was so necessary right now.
And when you talk about chronic disease and these huge numbers, the individual impact is just chilling. The source document points out that severe obesity cuts life expectancy by an average of 9.1 years for men.
9.1 years.
And 7.7 years for women. That's not just a minor risk factor adjustment. That is a huge chunk taken out of someone's potential lifespan.
It is. It's a massive impact. And when you realize that here in the U.S., we're talking about over 40% of adults living with obesity and nearly 10% facing severe obesity, well, the clinical community just can't keep managing it with half measures anymore. The evidence demands a more proactive approach. Okay, let's really dig into how we identify the problem then. Section 1 of the guidance focuses on redefining obesity and cardiovascular risk. For so long, the conversation started and often ended with just one number, BMI, the body mass index. What's the document's take on diagnosis now? Well, the standard definition of the disease itself hasn't changed. Overweight or obesity is still defined as abnormal or excessive fat accumulation that presents a risk to health. And BMI classification, remains the initial starting point, especially for broad screening purposes. We still use those familiar categories. Healthy weight is 18.5 up to just under 25 kilobeta 2. Overweight is 25 to under 30. And then you get into the 3 classes of obesity, with class 3 or severe obesity being a BMI of 40 or higher. That basic framework is still there.
But, pretty much every clinician and probably many listeners know that BMI is a pretty blunt tool, right? If you're, say, a bodybuilder, your BMI might flag as overweight or even obese, but clearly you're not carrying unhealthy levels of fat. What limitations does this guidance really focus on?
That's the critical piece. BMI is useful maybe for looking at large populations, tracking trends, but it's definitely problematic when you're assessing risk for an individual patient, and it fails because it completely ignores 3 really crucial factors. First, as you said, muscle mass. It can't distinguish muscle from fat. Second, it doesn't account for differences in body composition based on sex or race. People carry weight differently. And third, probably most important for heart health, is fat distribution. Where the fat is located matters hugely. Not all fat carries the same cardiovascular risk.
Okay, so that brings us to a really key clinical point raised in the guidance, the nuance needed for specific ethnic populations.
Precisely. This is vital. Because we know different ethnic groups tend to develop health risks at different body weights, The document specifically highlights proposed lower BMI cutoffs for people of South Asian and Chinese descent. For these groups, the guidance suggests considering overweight starting at a BMI of 23 kilobria 2 and obesity starting at just 25 kilobria 2.
So much lower thresholds than the standard were.
Much lower. And this correction is absolutely vital because studies clearly show these populations can have significant central adiposity, that belly fat, and the associated metabolic risks, even at BMIs that might be considered healthy or just overweight in, say, white European populations. If we fail to use these adjusted lower thresholds, we risk systematically underdiagnosing potentially serious health risks in literally millions of patients.
So if BMI is such a flawed tool on its own, especially for figuring out cardiovascular risk, what other measurements are now being strongly encouraged?
The ACC guidance really pushes for supplementing BMI with measures that actually quantify central adiposity. That's the visceral fat, the stuff stored deep around the organs, which is much more metabolically active and dangerous. These measures are much better predictors of actual cardiovascular events than BMI alone. Specifically, they point to using waist circumference.
Just measuring around the waist.
Yep. And also the waist-to-height ratio. These simple measurements help identify that dangerous internal fat, even in patients who might have a BMI that looks borderline or maybe even normal. The ideal diagnosis, as the guidance really frames it, isn't just about a high number on the scale. It's about evidence of excess adiposity plus some kind of impaired organ function or limitation in physical function. It connects the weight to actual health consequences. Okay, let's zoom out a bit to the causes. Figure 1 of the source document really lays this out. We all hear the simplistic idea that obesity is just eating too much and moving too little, but the document is crystal clear. It's way more complex. It's multifactorial. What are the main drivers this guidance points to?
Right. We absolutely have to move past that simplistic, often judgmental view. It's an incredibly complex interplay of factors. The guidance groups them into several key areas. Genetics plays a significant role, probably more than most people realize, influencing susceptibility. Then you have neurological and psychological factors. These govern appetite, how our brain signals hunger and fullness, cravings.
Things like satiety signals not working properly? Exactly. Hormonal imbalances are huge, too. The whole metabolic system can be disrupted in chronic obesity. And we can't ignore what are called iatrogenic causes. That means caused by medical treatment.
Like certain medications.
Yes, various medications, especially some used for mental health conditions or other chronic issues, are well known to promote weight gain. And finally, there are the huge and often very difficult to change social determinants of health. Things like lack of access to affordable, healthy food, no safe places to exercise, living in high-stress environments. All these contribute to creating the conditions where obesity thrives. It's a perfect storm, really.
And when all those different factors come together and lead to this complex disease state, what does it actually do to the heart and the blood vessels? How does obesity act as an independent risk factor for cardiovascular disease?
This is where the guidance is really stark. The damage is comprehensive. Obesity isn't just contributing to heart attacks indirectly because it often leads to diabetes or high cholesterol. It causes direct damage to the heart muscle and the overall cardiovascular structure. The document lists a really concerning range of specific CVD conditions linked directly to obesity. Figure 2 shows this clearly. We're talking atherosclerotic cardiovascular disease, that's plaque buildup, atrial fibrillation, irregular heartbeat, even sudden cardiac death, venous thromboembolism, blood clots, and valvular heart disease.
And the one condition that seems most tightly linked, especially in recent research, is heart failure, right?
Yes, absolutely. Particularly heart failure with preserved ejection fraction, or HFpEF. This is a type of heart failure where the heart muscle pumps strongly, but has become stiff and doesn't relax or fill properly. Obesity contributes significantly to this through mechanisms like volume overload. The heart has to work harder to pump blood through a larger body mass and persistent low-grade systemic inflammation. This inflammation over time causes harmful functional and structural changes in the heart muscle itself, leading to that stiffness. We clearly see an association between obesity and changes in the left ventricle, the main pumping chamber, making it thicker and less compliant. So understanding these direct mechanisms really hammers home why effective weight management isn't just about weight, it's about directly preserving heart structure and function.
So we've laid out the problem, the scale, the direct cardiac consequences, but how do we get to this point in terms of medical treatments? Section 2 in the guidance looks at the evolving landscape of weight loss therapies and, well, it's quite a history, isn't it? Filled with some cautionary tales. Let's take that quick historical detour the document mentions, starting with those first-generation meds.
Yeah, it's definitely worth looking back briefly to appreciate just how far we've come. The history of obesity drugs is, oh, it's pretty wild. Early attempts included things like thyroid hormone. The idea was to ramp up metabolism, but it was terrible for the heart, caused palpitations, other issues. Then there was a chemical called dinitrophenol, or DNP. This stuff literally made the mitochondria, the energy factories in our cells, leaky, so the body just burned off energy as heat instead of using it efficiently.
Wow, that sounds dangerous.
It was incredibly dangerous. It caused rapid weight loss, sure, but it was suspended way back in 1938 because it caused severe side effects like dangerous overheating, hyperthermia, rapid heart rate, and it even led to cataracts forming in people's eyes. It was basically toxic.
And the next wave involved things like amphetamines, which are stimulants. They're still around in some forms, but they were often used only short term, right? And they came with issues like dependency risk and not much long-term safety data for weight loss specifically.
Exactly. They were never really suitable for the kind of chronic long-term management that obesity requires. Then we entered what you could call the second generation of obesity medications. These included agents like Solostat, which blocks fat absorption, and combination pills like fentanyl and naltrexone. These were approved for longer-term use. But the problem was they only produced pretty modest weight loss on average. We're talking maybe 5.9% to 9.8% total body weight loss.
Which, okay, a 5% loss is definitely clinically meaningful, especially for reducing diabetes risk, as we'll discuss later. But it often wasn't enough to really reverse severe obesity or, crucially, to show clear benefits on hard cardiovascular outcomes like heart attacks and strokes.
That's the key point. These second-generation drugs largely lacked that definitive data showing they reduced M8 major adverse cardiovascular events. They helped people lose some weight, but the proof of heart protection wasn't really there.
And this is exactly where that huge treatment gap emerged that the guidance talks about. You had patients who couldn't achieve or sustain enough weight loss through lifestyle changes alone, but the available medications weren't powerful enough or proven enough from a cardiac standpoint to be true game changers. This sets the stage perfectly for what the document calls the modern pharmacological revolution, the arrival of the no-SH therapies.
Right. This third generation is fundamentally different because these therapies target the underlying biology, the hormonal control systems that regulate appetite and metabolism. NuSH stands for nutrient-stimulated hormone therapies. They directly interact with the body's complex signaling pathways, including tackling that stubborn concept of the weight set point.
Okay, wait, let's pause on that term, weight set point. Can you explain what that actually means, and why does it help explain why traditional dieting often fails in the long run for so many people?
Sure. The weight set point theory is essentially the idea that your body has a weight range it's biologically programmed to defend. Think of it like a thermostat for your body fat. When you lose weight, especially rapidly through just cutting calories, your body doesn't necessarily see that as a positive health move. It often interprets it as a potential starvation threat. So it fights back. It reacts by dramatically lowering your resting metabolic rate. You burn fewer calories just sitting around. And simultaneously, it cranks up the levels of hunger hormones, making you feel constantly hungry, preoccupied with food. It's a powerful, ancient survival mechanism designed to push your weight back up to that defended set point.
Ah, okay, so it's biology fighting against the diet.
Precisely. The new SH therapies work differently because they actually modulate those hunger and satiety hormones. They help to sort of reset or lower that defended set point, which is why the weight loss achieved with them tends to be more significant and crucially more sustainable as long as the patient stays on the therapy.
That makes a lot of sense. So how do the main agents we have now, semaglutide, liraglutide, and then the newer dual-action one, tirzepatide, actually work on these hormone pathways?
Okay, so the first major players here are the GLP-1 receptor agonists. GLP-1 stands for glucagon-like peptide 1. It's a natural hormone produced in your gut, released when you eat food. When we synthesize this hormone and administer it as a medication, it has several powerful effects. First, it stimulates your pancreas to release insulin, but only when your blood sugar is high, so it's glucose dependent, meaning it generally doesn't cause low blood sugar, hypoglycemia in people who don't have diabetes. Second, it significantly slows down gastric emptying. Food stays in your stomach longer, which contributes to feeling full. And third, and perhaps most critically for weight loss, it acts directly on appetite centers in the brain to increase feelings of satiety or fullness and decrease hedonic hunger, that's the craving-driven desire to eat, often for pleasure rather than actual physical need.
And that covers the mechanism for liraglutide and semaglutide. But then tirzepatide came along, which has been called a kind of superstar by some because it's dual action. What makes it different? Tirzepatide is indeed a bit different. It's a dual agonist, meaning it activates two different hormone receptors, the GLP-1 receptor we just discussed and the GIP receptor.
GIP stands for glucose-dependent insulinotropic polypeptide. It's another important gut hormone involved in metabolism. While GLP-1 is great for satiety and slowing the stomach, GIP seems to add another layer of metabolic control. GIP also stimulates insulin release, but research suggests it plays a strong role in regulating overall energy balance, possibly by further suppressing appetite signals in the brain. And importantly, it seems to modify how fat is stored and metabolized in adipose tissue itself.
So the working theory is that hitting both of these hormonal pathways simultaneously is what generates that significantly greater weight loss we see with tirzepatide in the clinical trials.
That seems to be exactly right. You're essentially tackling appetite regulation and metabolic dysfunction from two complementary angles, leading to a more powerful overall effect. This brings up a really important practical question then. Patient eligibility. Given that obesity is defined as this chronic relapsing disease, how should doctors decide who qualifies for these potentially lifelong treatments? Well, the basic criteria are still generally based on BMI thresholds, typically BMI $30 years, 37, if the patient also has weight-related health problems like hypertension or diabetes. Or, as we discussed, diagnosis can be based on direct measurement of excess adiposity linked to health issues. But the key policy shift highlighted in this guidance is, frankly, monumental for clinical practice. The ACC encourages clinicians to use the patient's non-pregnant lifetime high BMI when determining eligibility.
Lifetime high BMI, not just their current weight.
Exactly. This is a profound acknowledgement by the ACC of the chronic, often relapsing nature of obesity. We are treating the underlying disease trajectory, recognizing that weight regain is common, not just managing the number on the scale today. It reflects understanding that set point concept we talked about.
That is a powerful shift. And the other huge change mentioned is abandoning that old fail first approach with lifestyle changes.
Yes, this is critical. The guidance explicitly states that patients should not be required to try and fail lifestyle modifications before being considered for pharmacotherapy. This rejects the outdated, often implicitly biased notion that obesity is primarily a failure of willpower. If a patient meets the clinical criteria for medication based on their BMI and health status, pharmacotherapy can and should be initiated promptly, alongside, of course, ongoing lifestyle support. Think about it. We don't tell someone with dangerously high blood pressure to try harder with diet for 6 months before starting medication. We treat the risk immediately. The ACC is saying we should approach severe obesity with the same urgency.
Okay, let's talk numbers, because the efficacy data for this third generation of new SH therapies is really the reason we're having this entire conversation. What kind of weight loss figures are we seeing in the major trials? The guidance references figures 3A and 3B here.
The numbers are truly game-changing, especially when you compare them to that 5–9% average loss we saw with the older second-generation drugs. Liraglutide, which was one of the earlier GLP-1s approved for weight management, showed an average weight reduction of about 8.0% in its key trial scale. That's significant, definitely better than the older drugs, but it was soon surpassed. Semaglutide, specifically the higher 2.4 milligram dose used for weight management in the STEP 1 trial, achieved an average weight reduction of 14.9%, nearly double the effect of liraglutide.
Okay, 14.9%. That's a huge jump already. And then came tirzepatide, the dual agonist, pushing those boundaries even further.
Indeed, tirzepatide, in its pivotal SURMOUNT-1 trial, demonstrated an average weight reduction of a stunning 20.9% at its maximal dose.
Wow, over 20%.
Yes. Think about what that means for a patient. Someone starting at, say, 300 pounds could potentially lose over 60 pounds on average just through this medication combined with lifestyle support. That level of efficacy puts these medications squarely in the territory previously only achievable through bariatric surgery. And that's precisely why semaglutide and tirzepatide are now considered the agents of choice when initiating pharmacotherapy for obesity. Their superior efficacy really justifies this whole paradigm shift in treatment.
And for clinicians who are starting to incorporate these powerful tools into their practice, Table 2 in the guidance outlines some important logistical details. What are the key practical differences between these main agents?
Yeah, these practical aspects are really important for adherence, especially with chronic therapy. One major difference is the dosing schedule. Liraglutide requires a daily subcutaneous injection, which can be a barrier for some patients. Semaglutide and tirzepatide, however, are both administered as once-weekly injections. That's a significant advantage in terms of convenience and likely improves long-term compliance. There are also some differences in how they need to be stored after the first use. The semaglutide pen can typically be kept at controlled room temperature for up to 56 days. Liraglutide is about 30 days. Tirzepatide pens are only stable for 21 days at room temperature once started.
Okay, so little details, but they could matter for patients traveling or managing their medication supply.
They definitely can. These seemingly minor logistical points can actually have a big impact on a patient's ability to consistently stick with the therapy long-term.
Right. Now, we absolutely have to talk about safety. For drugs this effective, there must be important contraindications and side effects clinicians and patients need to be aware of.
Absolutely. Safety is always paramount. The universal contraindications are quite serious, but also relatively narrow. These drugs should not be used in patients with a personal or family history of medullary thyroid carcinoma, MTC, which is a rare type of thyroid cancer, or in those with multiple endocrine neoplasia syndrome type 2, MANAN2, another rare genetic condition.
So, careful screening for those specific histories is essential.
Yes, absolutely critical. Beyond those specific contraindications, the most commonly reported side effects are largely gastrointestinal. We're talking about things like nausea, diarrhea, vomiting, and constipation. These are pretty frequent, especially when starting the medication or increasing the dose.
So, how do clinicians help patients manage these GI side effects so they don't just give up on the treatment? Because nausea and vomiting can be pretty unpleasant.
That management strategy is really the key to success here. The secret sauce, if you will, is the dose titration schedule. It's absolutely crucial. Patients start on a very low initial dose, and then the dose is increased very slowly, typically only escalating every 4 weeks. This gradual ramp-up gives the body's gastrointestinal system and the endocrine system time to adapt and adjust to the medication's effects. If a patient does experience significant or bothersome side effects at a particular dose, the simple recommendation is to reduce the dose back down to the previously tolerated level for a while before trying to escalate again, or even stay at that lower effective dose. And the good news is that this strategy works well. In the major clinical trials for these non-USH therapies, the rates of patients stopping the medication due to adverse effects were actually quite low, generally ranging from about 4.3% to 7.1%. So while common, the GI side effects are usually manageable with careful titration.
Okay, that's reassuring. Let's shift gears now into section 3, which is really the core payoff for cardiologists and anyone concerned about heart health. We've established these drugs cause dramatic weight loss, but the guidance really forces us to connect those percentages directly to tangible improvements in cardiovascular and metabolic health. Figure 3A illustrates this well. What are the key clinical thresholds for weight loss that we should be aiming for, and what benefits do they bring?
This is where the conversation shifts definitively from weight loss as maybe a cosmetic goal to weight loss as a critical, life-saving clinical outcome. The document provides really clear benchmarks based on the evidence. Even achieving a relatively modest weight loss of 10% from baseline is considered clinically significant. Hitting that 5% mark is associated with a reduced risk of developing type 2 diabetes mellitus if you don't already have it, and it leads to measurable improvements in blood lipid profiles, specifically triglycerides, and better fasting blood glucose levels. So that 5% is kind of the foundational target, the first step.
Okay, 5% is good for metabolic markers. But for tackling some of the more established complications of obesity, like fatty liver disease or sleep apnea, we probably need to aim higher, right?
Much higher, yes. The guidance suggests that the 10% to 15% weight loss range is where you really start to see major improvements in comorbidities.
Right.
Losing 10–15% of body weight often leads to significant improvements, sometimes even resolution, of conditions like MFLD, that's metabolic dysfunction-associated steatotic liver disease, essentially fatty liver disease linked to metabolism. It also results in major improvements in type 2 diabetes control, reflected in lower HbA1c levels. And it can often significantly improve or even resolve obstructive sleep apnea, OSA. Most importantly, from a cardiology perspective, achieving this 10–15% threshold is associated with a clear reduction in overall cardiovascular disease risk factors.
And then there's the highest tier, over 15% weight loss. What additional benefits kick in there?
Hitting that 15% weight loss mark is where we see the most profound cardiovascular benefits in the available data. This level of weight reduction is associated with a reduced risk of cardiovascular mortality, dying from heart disease, and significantly improved outcomes, especially in patients suffering from that difficult-to-treat condition we mentioned earlier, heart failure with preserved ejection fraction, HFpEF.
Okay, this is where it gets incredibly compelling. The no-SH therapies aren't just improving risk factors like blood pressure or blood sugar, which is great, but they're actually shown to reduce hard MAC outcomes, major adverse cardiovascular events. The guidance highlights this in Table 3. How strong is the evidence for MAC reduction now?
The evidence is now considered definitive, and it's built on a series of large, well-conducted clinical trials. It really started with trials focusing specifically on patients who already had type 2 diabetes and established cardiovascular disease, a very high-risk group. The LEADER trial using liraglutide and the SUSTAIN-6 trial using semaglutide at a lower dose than used for weight loss alone both demonstrated a statistically significant reduction in the primary composite MACE outcome. That composite usually includes cardiovascular death, non-fatal heart attack, myocardial infarction, or non-fatal stroke.
Those were really important trials, but there was still a bit of a question lingering, wasn't there? Was the heart benefit seen in LEADER and SUSTAIN-6 primarily due to the drugs improving blood sugar control in these diabetic patients, or was there something more direct happening?
That was exactly the critical question, and that's the question that the SELECT trial was designed to answer, and its results really cemented the need for this ACC guidance. Why was SELECT such a game changer?
Tell us about SELECT.
SELECT was the pivotal moment where the paradigm truly shifted for many cardiologists. This trial studied semaglutide, the 2.4 milligram weight loss dose, but specifically in a large population of patients who had established atherosclerotic cardiovascular disease like a prior heart attack or stroke, and were overweight or obese, BMI 27, but crucially, they did not have type 2 diabetes. When SELECT showed a clear, significant reduction in the composite MACE outcome in this non-diabetic population, it provided definitive proof of one key thing. The cardiovascular benefits of these GLP-1-based therapies extend beyond just lowering blood glucose.
So the heart protection is, at least in part, independent of the diabetes effect.
Exactly. This confirmed that these therapies are treating obesity itself as a primary driver and modifier of cardiovascular risk, validating the entire approach the ACC is now advocating. It wasn't just about sugar control. It was about the weight loss and likely other direct effects of the drug. And now, building on SELECT, we're eagerly awaiting the results from similar large cardiovascular outcome trials currently underway for tirzepatide, the dual agonist. Trials like SURMOUNT-MMO and SURPASS-CVOT are testing tirzepatide in similar high-risk populations, both with and without diabetes.
Let's zoom in specifically on heart failure for a moment. It's a condition so closely intertwined with obesity, especially that HFpEF subtype. What specialized findings do we have for these non-USH therapies in the heart failure population? Table 3 touches on this too.
The results specifically in heart failure, particularly HFpEF, are some of the most compelling recent findings. The STEP-HFpEF trial, which tested semaglutide 2.4 milligrams in patients with obesity and HFpEF, showed really remarkable clinical benefits. Patients treated with semaglutide reported significantly improved heart failure symptoms, less physical limitation, and objectively better exercise function compared to placebo. And interestingly, the magnitude of the benefit seemed related to the amount of weight lost, but researchers suspect there might also be direct beneficial effects of the drug on inflammation and heart muscle metabolism itself.
So, improved quality of life and function. What about harder outcomes in HFpEF? That's where the recent tirzepatide data comes in. The SEMENT trial, also focusing on patients with obesity and HFpEF, just recently reported its findings. It showed that tirzepatide led to a significant reduction in a tough composite outcome, the combination of cardiovascular death and worsening heart failure events like hospitalizations. The hazard ratio was 0.62. Hazard ratio of 0.62, that means roughly a 38% reduction in risk for that combined endpoint.
That's right. A very substantial reduction. This isn't just making people feel a bit better, it's potentially preventing major downstream events. These results firmly established no-EFH therapies, both semaglutide and tirzepatide, as fundamental new tools in the comprehensive management of HFpEF in patients with obesity.
Okay, so we have these powerful medications causing significant weight loss and improving major outcomes. But managing these complex patients, especially as they lose substantial weight, surely requires a level of coordination between different medical specialties that maybe wasn't as critical before. What does the guidance say about the need for multidisciplinary adjustments?
You've hit on a crucial point. A coordinated, multidisciplinary approach is absolutely non-negotiable when using these therapies effectively and safely. Figures 6 and Table 4 in the guidance really emphasize this. Perhaps the most important theme, especially after significant weight loss occurs, is the need for careful de-escalation of other existing medications to avoid overtreatment and potential harm. The cardiology team, for instance, must be incredibly vigilant. As patients lose weight, their blood pressure often improves and their fluid balance can change. This means antihypertensive medications and diuretics frequently need to be reduced, sometimes quite quickly, to prevent dangerous side effects like low blood pressure, hypotension, or becoming dehydrated, intravascular volume depletion.
That sounds like a serious risk, especially for older patients or those who already have underlying heart failure or kidney issues. What kinds of adjustments might be needed from other specialists, like endocrinologists or gastroenterologists?
Endocrinology plays a critical role, particularly for patients who also have type 2 diabetes. As weight comes down and insulin sensitivity improves thanks to the no-SH therapy, endocrinologists must proactively reduce doses of other diabetes medications, especially insulin itself and drugs called sulfonylureas, to prevent potentially life-threatening hypoglycemia, low blood sugar. They also need to keep an eye on thyroid function. Levothyroxine doses for hypothyroidism are often based on weight, so as weight decreases significantly, the thyroid hormone dose may need to be adjusted downwards. Checking TSH levels periodically is important. Gastroenterology has a different set of considerations. While weight loss might allow some patients to reduce medications for acid reflux, clinicians need to be aware of and counsel patients about a known association between non-ESH therapies and an increased risk of gallbladder problems, specifically gallstones, cholelithiasis.
Oh, really? An increased risk of gallstones?
Yes, it seems to be related to changes in bile composition and gallbladder motility associated with rapid weight loss and the drugs themselves. So for patients who already have known gallstones, some guidelines suggest considering prophylactic treatment with a medication called ursodiol to help prevent complications while they're on no-SH therapy.
Interesting. And even surgeons and anesthesiologists get pulled into this conversation, right? Regarding managing these drugs around the time of surgery.
That's right. Although the evidence base is still evolving, there's growing awareness and some emerging guidelines about managing GLP-1 agonists before elective surgery. Because these drugs significantly slow gastric emptying, there's the theoretical concern about an increased risk of aspiration stomach contents coming up into the lungs during anesthesia. So current recommendations often suggest holding the weekly injectable GLP-1 agonist for about 1 week prior to surgery. This requires really close communication between the surgeon, the anesthesiologist, and the clinician managing the weight loss medication. Okay, so the clinical data is overwhelmingly positive, the mechanisms are becoming clearer, and the cardiovascular benefits are undeniable. But Section 4 of the guidance pivots to address something equally important and frankly more systemic and perhaps ethical: the barriers patients face and the overall patient experience. The ACC guidance puts a really strong emphasis here on reducing weight bias and stigma within the clinical setting itself. This is absolutely paramount, and the guidance is right to highlight it so strongly. It goes way beyond just, being polite or politically correct. We know from research that weight bias and stigma experienced in healthcare settings directly leads to negative consequences for patients. It can cause patients to avoid seeking necessary care, lead to delays in diagnosis, foster distrust in the medical system, and ultimately contribute to poorer health outcomes. It's a real barrier to effective treatment.
So what practical steps does the guidance recommend clinicians take to actively combat this bias in their daily practice? Figure 4 touches on this.
It starts with language. Clinicians are urged to consistently use person-first language, for example, referring to a patient with obesity, rather than labeling someone as an obese patient. It seems subtle, but it frames obesity as a medical condition the person has, not defining who they are. But beyond language, the physical environment of the clinic or hospital is often one of the biggest, most tangible sources of stigma and discomfort. Figure 4 again.
What kind of physical accommodations are we talking about needing? Things like chairs and equipment.
Exactly. We need to ensure the physical space isn't implicitly hostile or unwelcoming to patients living in larger bodies. That means practical things like having sturdy, armless chairs or wider chairs available in waiting rooms and exam rooms. It means having high-capacity weighing scales readily available and used respectfully. Scales properly calibrated and rated for weights well over, say, 400 pounds. It means having robust exam tables that feel secure. Even simple things matter, like routinely having large and extra-large blood pressure cuffs available and using the correct size without making a fuss. Or ensuring that higher capacity equipment is accessible if needed for imaging like CT or MRI scans. If a patient comes into a clinic and the chairs are too small, the gown doesn't fit, the scale doesn't go high enough, or the blood pressure cuff is painfully tight, they immediately feel shamed, alienated, and othered. That completely undermines the trust and therapeutic relationship needed for managing a chronic condition like obesity long-term.
And that long-term relationship is key because the patient journey outlined in Figure 5 really emphasizes that this isn't a quick fix. Obesity is presented as a chronic disease demanding lifelong management strategies.
Absolutely. This is not a 12-week challenge or a temporary diet. The guidance frames obesity management as a commitment to ongoing lifelong care, similar to how we manage hypertension or diabetes. The initial goal might be achieving that clinically significant dead 5% of weight loss we talked about. But if that goal isn't met, or if weight starts to creep back up later, the treatment plan needs to be actively managed and potentially escalated, perhaps by changing medications, increasing the dose if tolerated, or even considering adding synergistic agents. The guidance stresses the need for, at minimum, annual follow-up appointments specifically dedicated to reviewing the weight management plan, monitoring progress, addressing barriers, and adjusting the long-term strategy. But really, for many patients starting these therapies, much more frequent check-ins, especially early on, are essential for support and sustained success. And that ties directly into the reality of chronic treatment that you mentioned earlier. If a patient stops taking these no-yesh medications, the weight often comes back, right? Because the underlying biology, that defended set point, hasn't fundamentally changed. That is the biological reality, unfortunately. Long-term, potentially lifelong treatment is generally considered the default plan or expectation with new SH therapies, precisely because weight regain is the expected physiological norm upon discontinuation. The body wants to return to its previously defended weight. The longest published randomized controlled trial specifically for a new SH therapy used for obesity, which was liraglutide, followed patients for 3.8 years. However, we do have longer-term observational data extending out to 5 years or more for some GLP-1 agents used initially for diabetes, which supports their general long-term safety profile. The crucial point here is shared decision-making. Discontinuation of therapy shouldn't be taken lightly. It should only happen after a thorough discussion between the clinician and the patient, explicitly acknowledging the high likelihood of weight regain and consequently the potential return of the associated cardiovascular and metabolic risks that the treatment was successfully managing. Persistence with therapy, when tolerated and effective, is vital for protecting long-term health, especially heart health.
Okay, now we arrive at what is arguably the biggest elephant in the room, the toughest systemic barrier discussed in the guidance: access and affordability. Despite all this incredible data on efficacy and life-extending cardiovascular benefits, these medications are often prohibitively expensive, creating a massive ethical and practical challenge. The cost barrier is, frankly, staggering, particularly in the United States. The guidance provides some sobering figures. To give you an idea of the scale, the average annual list price in the U.S. for semaglutide 2.4 milligrams of Wegovy is around $14,080. For liraglutide 3.0 milligrams Saxenda, it's even higher, about $15,738 per year. Tirzepatide, Zepbound, is currently priced slightly lower, around $8,126 per year. But still, these are enormous sums of money, often falling entirely on the patient as out-of-pocket costs.
Wow, those numbers are eye-watering, especially when compared internationally.
Exactly. The guidance notes the stark contrast with international prices. For example, liraglutide costs only about $2,066 per year in Switzerland. That huge disparity highlights major issues with drug pricing and market access, specifically in the U.S. system.
This massive cost inevitably forces patients and the healthcare system itself into a really difficult position. Why is insurance coverage, especially through government programs like Medicare, so inconsistent or limited for these drugs when used specifically for obesity?
It largely boils down to historical inertia and outdated policy definitions. For decades, obesity was often categorized implicitly or explicitly by payers as a lifestyle choice or cosmetic issue, rather than being fully recognized and reimbursed as the complex chronic disease that all the medical evidence now shows it to be. So, while Medicare Part D, for example, will generally cover these GLP-1-based drugs if the patient has a diagnosis of type 2 diabetes, or sometimes if they have established cardiovascular disease, because those are considered hard medical outcomes, they typically do not cover these same medications solely for the indication of obesity itself, even if the patient has a very high BMI and multiple other obesity-related risk factors like hypertension or sleep apnea.
So the label matters more than the underlying risk.
In many cases, for coverage purposes, yes. This policy creates a significant and often insurmountable access roadblock for millions of patients who could clearly benefit. It forces many into an impossible choice between their health and their finances.
And if patients can't afford the FDA-approved branded medications through legitimate channels, what are the dangers if they're tempted to seek out cheaper, unregulated alternatives, like from compounding pharmacies or online sources?
The ACC guidance issues a very strong warning against pursuing these unregulated routes. The risks associated with compounded new SH therapies or products bought from unverified online sellers are substantial and potentially very dangerous. Because these medications are complex peptide molecules, ensuring their purity, stability, and correct dosage requires stringent manufacturing controls. When you get them from unregulated sources, there are serious risks of receiving a product with incorrect dosing, potentially harmful impurities or unknown fillers mixed in, or even getting an outright counterfeit agent that contains no active drug at all, or worse, contains something harmful.
So zero efficacy and unknown safety risks.
Precisely. Using these unregulated products is highly discouraged. Until the fundamental issues of pricing and insurance coverage are addressed systemically, this gap unfortunately drives a real public health concern, pushing desperate patients towards potentially unsafe options. Continued advocacy is absolutely needed to get obesity fully recognized and treated as the serious chronic disease it is, warranting comprehensive and affordable access to proven therapies.
Okay, so pulling all of this together, after digging through this comprehensive ACC guidance, what's the ultimate summary? What does this all really mean for the practicing cardiologist, the primary care provider, and most importantly, for the patient sitting in front of them?
I think the main summary is that the American College of Cardiology has delivered a clear, decisive, and practice-changing statement. We are officially in a new era, where proactively managing obesity is no longer optional or secondary. It is unequivocally recognized as an essential component of comprehensive cardiovascular disease, risk mitigation, and treatment. The newest generation of new SH therapies, particularly semaglutide and tirzepatide, are now validated not just for their impressive weight loss effects, but critically, because they deliver demonstrable reductions in major adverse cardiovascular events, MACE, in high-risk patients, even those without diabetes. Furthermore, they profoundly improve functional status and outcomes in challenging conditions like heart failure with preserved ejection fraction, HFpEF. The focus has decisively shifted from simply treating the number on the scale or treating weight for appearance towards strategically managing weight and adipose tissue to directly protect the structure, function, and longevity of the heart.
And if we connect this deep dive back to the bigger picture, the source material strongly suggests this is really just the beginning of this therapeutic revolution. Where do you see things heading next in the intertwined fields of obesity management and heart health?
That's the exciting part. The trajectory is clearly towards even more personalized, targeted, and potentially even more powerful medical therapies for obesity and its complications. We already have multiple new drug candidates in late-stage development, targeting additional or different hormonal pathways involved in appetite and metabolism pathways involving hormones like glucagon and amylin. This will likely offer clinicians and patients more choices, potentially allowing for combination therapies tailored to individual patient needs and responses, much like we do now for hypertension or high cholesterol. We're also getting better, technologically, at precisely identifying and quantifying that harmful visceral adipose tissue, moving beyond just BMI and waist circumference. So the cardiovascular community, as evidenced by this ACC statement, has fully embraced medical obesity management as a core part of its mission. The science is moving rapidly. The really big open question that this guidance leaves us with is this. Given the overwhelming evidence showing the profound, life-extending cardiovascular benefits these therapies provide, how quickly can the broader healthcare system, insurers, pharmacy benefit managers, policymakers, government payers adapt? How quickly can we dismantle the outdated policies and overcome the significant cost barriers to ensure equitable access to these transformative therapies for every patient who stands to benefit? That adaptation, bridging the gap between the scientific evidence and real-world patient access, is perhaps the greatest challenge and the greatest opportunity that lies before us now.
Thank you for watching The Funnel Effect.